the most common symptom, neuropsychiatric symptom that affects the persons with prolonged illness. And delirium is most distressing for the patient as well as the caregivers, and also for the staff also, creating a lot of suffering. At the same time, it extends the hospital stay, causing much unwanted expenditure on the part of the patients and their relatives. Another issue is that delirium is the harbinger of imminent death sometimes. Unfortunately, delirium is under-detected and under-treated. So it is very important to know the what delirium is, how to diagnose it, what are the clinical features, and what are the pathogenesis of delirium, and how to manage it. We'll cover it one after another. Delirium can be defined as is a complex syndrome with multifactorial etiology characterized by disturbance of cognition, arousal, and attention. The main components are impairment of the consciousness and global disturbance of cognition, psychomotor disturbance, and emotional disturbance, and the disturbance of sleep-wake cycle. And what are the cognitive defects? Attention, there will be lack of attention. Orientation to time, place, and person is lost. Short-term and long-term memory is impaired. And executive function, which leads to difficulty in activities of daily living. Then there is perceptual disturbance, like illusions, hallucinations, in particular visual, and metamorphosis, seeing something as something other. It's metamorphosed to something else. Then delusions, paranoid delusions. Then thought disorders, tangentiality, circumstantiality, and loose association. Tangentiality is when he starts talking about something, he loses the focus and goes to something else. Circumstantiality is explaining the circumstance leading to a particular thing. He never reaches the point of interest. Before that, he describes the circumstances leading to that. So that is circumstance and loose associations. Then there will be disturbance in the sleep-wake cycle, fragmented sleep, reversal of normal sleep-wake cycle, and sleeplessness. And there are language disturbances, word finding difficulty, paraphasia, dysnomia, dysgraphia, then altered affect, incongruent mood to the context. He may be telling something very sad, but he may be smiling. Anger, increased irritability, hyperactivity, misdiagnosed as depression, lability, fear. That is the altered affect. Then there are motor behaviors, changes in motor behavior, like increased or decreased activity, increased or decreased speed of action, loss of control of activity, then wandering, aimless wandering, restlessness, combativeness, apathy, listlessness. Delirium has a few subtypes like hyperactive, hyperactive, and no subtype. Hyperactive appears lethargic and drowsy, responds slowly to questions, do not initiate movement, and have reduced awareness of the surroundings. Hyperactive delirium can be easily confused with depression. And how can we differentiate hyperactive delirium from depression? One is the onset and the fluctuating nature. The onset is abrupt and there will be fluctuating course for delirium, whereas in depression it is insidious and there will not be any fluctuation. And there will be more thought disorders, attention deficit in um, delirium, whereas that attention deficit is not that marked in uh, depression. Then hyperactive have restlessness, agitation, and psychomotor overactivity. Perceptual disturbances and delusions are more common in this subtype than in hyperactive delirium. And for the same reason, this hyperactive delirium can be confused with maniac reactions. Here also, the abrupt onset and the fluctuating course differentiated from mania. And there will be no subtype, minimal motor activity changes. These are the three types of delirium. And how to diagnose? We use the confusion assessment method, CAM. A patient is CAM positive if their confusion has an acute onset of fluctuating course and the patient has inattention, and these are the two things, major things: acute onset of fluctuating course and the patient has inattention, and either one of the two, disorganized thinking, or they have an altered level of consciousness, which can be hypo or hyper alert. So common etiologies: infection. In old age, especially in old age, sometimes infections will not have the classical clinical picture. These patients present as delirium. So infection is one cause of delirium. In old age, there's pneumonia. It doesn't have the classical feature of clinical feature of pneumonia, but the patient may be delirious, and by investigating the person, then only we understand that it is pneumonic consultation. So infection is one cause, urinary infection, substance withdrawal, alcohol or nicotine, then metabolic abnormality, hypercalcemia, hyponatremia, hypoxia, and psychoactive medications, corticosteroids, opioids, anticholinergics, and benzodiazepines. Then predisposing factors for delirium, risk factors are old age, physical frailty, multiple medical comorbidities, dementia, admission to hospital with infection or dehydration, visual impairment, deafness, polypharmacy, renal impairment, and malnutrition. These are all predisposing factors for a particular person to become delirious. And the management, there are pharmacological and non-pharmacological management. Pharmacological management, there is antipsychotic. The haloperidol is the drug of choice. 0.5 to 2 milligram every 2 to 12 hours per oral, IV, IM, subcutaneous. Extrapyramidal adverse effects can occur at higher dose, more than 5 milligram. Then only we get extrapyramidal symptoms. Otherwise, it is safe to give haloperidol. Sometimes we have to monitor QT interval on electrocardiogram. Then haloperidol remains the gold standard therapy for delirium. If we can add lorazepam, if the delirium is not controlled over haloperidol, then we can add lorazepam or then midazolam, etc. Chlorpromazine is another choice, 12.5 to 50 milligram every 4 to 6 hours per oral, IVIM, subcutaneous, parenteral. More sedating and anticholinergic compared with haloperidol. That's an advantage and disadvantage. So, we had to monitor blood pressure for hypotension. So, as it is sedating, can be preferred in agitated patients due to sedative effect. So, haloperidol, we initial management is with haloperidol, but in delirium tremens, we use benzodiazepine. You may be knowing the reason, because chronic alcohol use will downregulate the GABAergic neurons and upregulate the glutaminergic neurons. And so, when the alcohol is stopped, there will be an imbalance between uh, GABAergic and glutaminergic neurons. And so, there will be an over-excitability by the glutaminergic neurons. So, to counteract, we can give benzodiazepine, which is a GABAergic drug. So, that's the reason for giving benzodiazepine for delirium tremens. All other delirium, we can give haloperidol as the first choice. And we can give atypical antipsychotics like olanzapine, risperidone, quetiapine. Non-pharmacological interventions include reducing the polypharmacy, try to give as minimum drugs as possible, and control of pain, sleep hygiene, and monitor for fluid electrolyte disturbances, monitor nutrition, and monitor for sensory deficits. Encourage early mobilization. Minimize the use of immobilizing catheters, intravenous lines, and physical restraints. Then monitor bowel and bladder function. Constipation is a common cause for delirium. Reorient the patient frequently. If uh, the just shifting the patient from his familiar surrounding itself can precipitate delirium. So when the patient is admitted in the hospital, reorient the patient frequently, where he is lying down, what is the time of the day, who are the caregivers, etc. And place an orientation board, clock, or familiar objects in the patient's room. That will be very helpful for the patient. And encourage cognitively stimulating activities. Now we come to terminal delirium, present as confusion, restlessness, and or agitation with or without day and night reversal. There may be mourning and or groaning. It's usually irreversible. Then the major problem is that family members remember it as a horrible death in terrible. So how can we manage it? The causes are infection, medicines. What all medicines can cause delirium? Tricyclic antidepressants, morphine, anticholinergics. All these things can cause. So we have to review all the medicines. Metabolic abnormalities like hyperthyroid, hypercalcemia, hyponatremia, hypoxemia, fecal impaction, urine retention. All this can cause uh, delirium in the terminal stage. Renal or hepatic failure and simple change of environment itself can cause delirium. And how to manage? If not actively dying, we can treat the cause. We can investigate and uh, find out any electrolyte imbalance or anything like that. Correct it, correct the correctable. If death is imminent, manage the symptom. Reassure the family. Tell them that what the patient experience may be very different from what the on the patient. The drug of choice is haloperidol, 1 milligram IV. Benzodiazepine can be added. Because it's the overview of delirium. Now we can come back after seeing the case study and then we can have the discussion. Thank you.
Thank you, Doctor. Sir, would you like us to move with the case presentation now?
Yeah.
Then can we take up the questions? Yes.
Yeah, please.
Yes. Dr. Nafisa, I welcome you for the case presentation. Gayatri, kindly project the PPT.
Hello. Hello.
Yes, sir. You are audible.
Can you hear me? Am I audible?
Yes.
Yes, Dr. Nafisa, please proceed.
Yeah, okay. Yeah. Okay. Good afternoon to all the faculty attending the session. Um, at the beginning, I would like to thank the coordinator, Gayatri, Dr. Hashmat, and the team of Pallium India for giving me the opportunity to present this case for the day. I would like to go ahead with my case. I'm Dr. Nafisa Catherine Vaz, Medical Officer attached to Primary Health Center, Bali, and the Directorate of Health Services, Goa. Like to move on with the case. Was a patient of 50 years, male, had diagnosed with alcoholic liver disease, with hypertension, with head injury, with the left basal bleed, with right hemiplegia and delirium. Next slide. The presenting complaints, the patient had inability to move the right upper and lower limb since 1.5 months. Had oral intake since 1.5 months. Patient presented with restlessness that he was picking up on the bed sheet, Ryle's tube IV line with the left hand, that was normal, since the 8 to 10 days. Presented also with irrelevant talking and confusion for the past 8 to 10 days. Had disturbed sleep patterns for the 8-10 days and had also passing high colored urine, which was cloudy and turbid with fever for 7 to 10 days. Next slide, please. Yeah. History of the illness. Patient was a chronic alcoholic. 1.5 months back, under influence of alcohol, patient had head injury, which was secondary to hypoglycemia with loss of consciousness, for which the patient was transferred by 108 ambulance to the tertiary government hospital. Patient was diagnosed as a case of alcoholic liver disease with hypertension, with head injury, with the left basal bleed, with right hemiplegia. Patient developed restlessness, irrelevant talking, confusion since the 8 days back, had sleep disturbance for the same days. Poor oral intake was for almost 1.5 months, along with the hemiplegia. Passing of high colored urine with fever was for the past 7 to 10 days. However, the patient's wife left against medical advice from the tertiary hospital and got admitted at the nearest government health center. Next slide, please. Yeah. On examination, the patient was conscious. He was confused, disoriented to time, place, and person. He was afebrile, having a pulse of 86 beats per minute. Blood pressure was 110 by 70 millimeters of mercury. The respiratory system was clear. On central nervous system examination, bone had reduced on the right side, upper and lower limb, and it was normal on the left. The power was grade 1 on the right and grade 5 on the left. Other systems had no obvious abnormal findings. The patient had a Ryle's tube, tracheostomy, and Foley's catheter in situ. Next slide, please. Yeah. The investigation details. The patient had an hemoglobin of around 12.4 grams per deciliter, total count of around 8,000 cells per microliter, blood urea 17 milligrams percent, serum creat 0.8 milligram percent. Chest X-ray was within normal limits. CT scan brain showed left basal bleed. Next slide, please. Yeah. Coming on to the psychosocial aspects, patient was a chronic alcoholic, 50-year-old male, married, living with his 45-year-old wife, having a 7-year-old school-going daughter residing in their own house. He was unemployed for the past 3 years because of his alcoholic status. Wife works as a maid in the neighborhood and is a breadwinner of the family. Now, for the past 1.5 months, she has been in the hospital attending to her husband. Her child has been kept at the relative's place. Next slide. Next slide, please. Yeah. The patient was on various medications like antihypertensive amlodipine 5 milligram once a day, levetiracetam, that is Levepsy 500 milligram thrice a day, paracetamol 500 milligram thrice a day, cefuroxime 500 milligram BD, tebrifaga twice a day, UDHAP twice a day, lorazepam 2 milligrams HS, and the patient was advised to follow up at the neurosurgery OPD at the tertiary government setup, SOS. Next slide. The main concerns here were restlessness and confusion, sleep disturbance, passing of high colored urine, was turbid. Patient had fever, and the financial problems were the other concern. Next slide, please. Yeah. Coming on to the summary, the patient was a chronic alcoholic, 50-year-old man with head injury, with right hemiplegia, with restlessness, confusion, sleep disturbance, passing turbid high-colored urine with fever. Yeah. So the discussion points was how can we manage this restlessness, confusion in this patient? How to deal with the sleep disturbance? How can we provide the patient and his wife with psychosocial support and also caregiving responsibilities?
Thank you, Dr. Nafisa. So before we move into the comments from Dr. Divakaran sir, there are a few questions in the chat box regarding the patient stories from participants. So the question from Dr. Dilip is, when was the CT scan done?
Yeah, the CT scan was done the same day he had the head injury. Means he had met with an alcoholic influence. He had LOC and that was secondary to hypoglycemia. The same day it was done. Basically, we have followed up with the papers that the patient had signed LAMA and come from the government setup, the tertiary hospital. So they came, they signed LAMA and they came to our hospital. So this is all based on the records and her history. So we couldn't really shift the patient again for any CT scan or anything off late. But recently the patient had seizure, so we had to refer the patient back to the district hospital. And the patient is admitted there as of now. So the patient is shifted from our center.
Okay, so there's one more question. Why patient was shifted from one government setup to another? And also Dr. Ravindra says that hepatic encephalopathy might be a reason.
Yeah, probably. But actually the wife had no help. It's just she is not been treated well by the family members. So there was no one to help her. Even at the our hospital when they were admitted, there was no one to relieve her. So she was like totally in distress. So because she couldn't manage with her husband there in the tertiary setup and it was quite away from the residence, she preferred to sign against medical advice and come and get admitted at our nearest health center. And we could see that she was stressed because even the daughter was left with the relatives and she was wondering like whether the child has been eating well, whether she's been going to school, she's been attended well by the relatives, whether they're treating her well or ill treating her, whether she's studying, all she was stressed out. And of late also when the patient threw a seizure on the duty, we referred the patient, but even that time she was hesitant to go. But because we explained to her that effects, therefore she agreed and now presently they are admitted at a district hospital.
Okay, thank you, Dr. Nafisa. Dr. Divakaran sir, would you like to add your comments on the discussion points that Dr. Nafisa has brought in for discussion here?
As she has already said, because it's a very tragic situation. The husband is an alcoholic and not going for work for the past 3 years. And
3 years.
She
3 years. Yeah, he's been unemployed for the past 3 years.
Yeah.
And she's the only breadwinner.
She's the only breadwinner. And for the past 1.5 months, she could not go for her work also. And
Yes,
she has to part with her son, 7-year-old boy. So very sad state of affairs. And not very uncommon also in this part of country also. We see quite often such a scenario. The husband is a drunkard and he becomes ill frequently and the wife has to look after her. So that's the situation. So she cannot afford to take care of on the tertiary hospital, which is far away, and so she has discharged her and got admitted in a nearby hospital. So there is nothing wrong in her choice of this thing. Now, what about the another point was discussion point was what was the next discussion point?
Sir, the first discussion point is how can we manage this patient's restlessness and confusion?
Okay. And this is a case of delirium. probably multiple etiological factors there. His head injury itself can be a cause for delirium, and he was febrile. That means he has some infection. That infection can be another precipitating factor. Alcohol withdrawal, unlikely, because alcohol withdrawal happens 48 to 72 hours after the last drink. Now he has been in the hospital for so many days and 1.5 months, and delirium started only 8 days back. So withdrawal is unlikely, but at the same time, hepatic encephalopathy can be a cause because he is a chronic liver disease patient. It can be a hepatic encephalopathy. In that case, there will be a problem with ammonia encephalitis, and we have to see whether he is passing stool, and we have to give liberal dose of laxatives to clear up his bowels. And of course, we can give haloperidol for controlling the symptoms.
Yes, sir. So the next question is how to deal with the sleep disturbance.
Any suggestions from candidates?
Yes, participants, you can post in the chat box regarding how you will manage your sleep disturbance.
Will this the haloperidol itself will help for this?
Sorry, I didn't hear. Will haloperidol is alone can
sleep,
relieve?
yeah.
Yeah, of course, if haloperidol is not enough, we can give lorazepam.
But he's
of
already
course.
on lorazepam, no, doctor?
Yes, yes. He's already on lorazepam 2 milligram HS that was started by the surgery hospital.
Okay. I think we can see whether a combination of haloperidol and lorazepam will work. Otherwise, we have to think about other how to maintain the sleep hygiene, non-pharmacological approaches like quiet atmosphere, that sort of sleep hygiene can be tried.
Okay.
Sir, I have a question here. Will melatonin help with his sleep disturbance in this scenario?
Yeah, quite possible. Melatonin. Yeah. The sleep-wake disturbance is there in delirium. So to regularize that, bring back the circadian rhythm, you can use melatonin, 4 milligram.
Is melatonin available
Yeah.
easily?
Yeah, it's
no,
available.
No, we don't have it here with us. Okay, any other alternative for that, doctor, besides melatonin?
So, sir, I think
Hello?
one of the doctors was asking whether there is any more alternative apart from melatonin.
Yeah,
so, I think one thing what sir mentioned was the sedatives like lorazepam. Apart from that, melatonin can also be tried, what doctor is mentioning here.
Then we can try atypical antipsychotics like
what is the cost of melatonin?
melatonin is not that costly. You can be afforded.
Okay, sir. Okay, sir. Then we can ask with local purchase because the government supply also we don't have. Ours is a government setup, so being a primary care, that so I'll have to, I'll have to speak to the higher ups for local purchase, if possible.
We can go into selected patients only.
Yes. Sir, there was one more question. I think you partially answered that. How can we provide the patient and his wife with the psychosocial support and caregiving responsibility?
Yeah. So many of the problems they are facing has a non-medical component. Doctor or nurse cannot solve all these problems. So we have to have the help from the community. So we have to participate the community, like volunteers in the community. We can take the patient to one of our palliative care center where there is inpatient facility for a respite care, so that she can be relieved of her stress for some time, at least for a few weeks. By the time she can recharge and take care of her husband. That's one thing. And we can try to rehabilitate rehabilitation measures like making some paper pen or something like that while she is in the hospital itself, taking care of her husband. Side by side, she can work on some earning projects. That's with the help of the local palliative care unit and the community's help. And take care of the child's education. That way we can minimize the distress of the patient and family.
Yes, yes, I think that answers the question. Any more questions from the participants? So as Sir mentioned, respite care is something which is very commonly practiced in palliative care, where when the caregivers have a fatigue and when there's a caregiver burden, they come to our sitting and we take care of them for a few days. If they are really stressed, they can go and then recharge and come back to take care of them again. So that really offers support in such situations.
Yeah.
Dr. Nafisa, do you have any more questions to ask? Or any other person?
We had actually asked our district hospital palliative care team to actually, come and help us with the physiotherapy and all. Since the patient is on tracheostomy and he's also hemiplegic on one side. So anything y'all can suggest, like with regards to this? Means we have done this physiotherapy part. We have asked the palliative care team to come and help us with that. But now presently he's been shifted because of his seizure episode to district hospital. So once he's back, like anything else that we can do from the patient point of view? Plus, because of his restlessness, he was picking on the IV line and causing bloodshed. So we have to remove the IV line also because the urine was continuously high color, turbid with deposits and all, and the fever. So now at the district hospital, they might do.
Couldn't hear the last part.
Sir, I think Dr. Nafisa has a network issue because even before she was presenting, there was break in between.
Yeah.
So she was asking about the neuropalliative care approach to this patient, where how we can start with physiotherapy and all of that. And eventually, the last part that she was mentioning, I also missed. I do feel that for this patient, the rehabilitative approach is really needed. Slowly, after he becomes better, then we can start rehabilitating this patient and provide physiotherapy. Maybe a physiatrist might be the right person to assess this patient and find out what are the components that we can put in to improve this patient care. Maybe the physiatrist as well as the physiotherapist together can contribute a lot on that. And frequently, we also see patients with stroke who come back to us for rehabilitation. And it takes a little bit of time, but then definitely when things are being provided in the right time, and also if there is someone to support and uh, rehabilitate this patient in a better way, the outcome is really good. But it is not the same for all patients, so I do feel a physiatrist is the right person to assess that and come to a conclusion.
And of course, there is nothing to substitute the good nursing care, prevention of bed sore by proper changing position frequently, pressure reducing mattress, that sort of thing. At the same time, we have to be wary about restricting the movement, because restricting the movement is can aggravate delirium. So here the patient pulling out the nasogastric tube and IV line, that's a very tricky subject. How can we manage it? Physical restraint is one option, but physical restraint is in a way inhuman, and at the same time it can aggravate delirium. So we should be able to work out something better than a physical restraint. We can have a pharmacological restraint, or we can give some covering the palm with some sort of glove or something, and then bandaging it so that the patient cannot open his fingers and pull out the nasogastric tube. That's an option.
Yes, yes, sir, rightly said. And also to look into all the reversible causes of delirium that sir had discussed in the session. We have to rule out all of that and correct the correctables. That plays a major role in managing delirium. And also the non-pharmacological measures like maintaining the sleep-wake cycle, all these things, keeping a clock in the room, simple things actually helps a lot in managing such patients. And very commonly when patients are bedridden, we see that they are constipated, and constipation itself is a cause for delirium, which we actually leave. We don't find it. We think it's just a constipation, but then many a times when patients come to us, they are really very delirious. But the one of the cause would be constipation. Correcting that at the right time, because these bedridden patients are more prone for constipation. So laxatives and all of it, how you're managing all that really matters. And when you correct all the correctables and all the reversible causes, definitely the quality of care also gets improved, and this patient will actually perform better. That is what I understand based on all the discussion. So apart from that, there are any more questions? I don't see there are questions in the chat box, but if there are any, we are ready to take it up, and sir is also there.
As he is an alcoholic, we can ensure that he alcoholic and having liver disease, ensure that his bowels are evacuated properly. So that we can give lactulose. I think already we have mentioned that. And another thing, we can prevent vernix encephalopathy by giving thiamine for this patient, 500 milligram over 3 to 4 minutes, 2 or 3 times daily for 5 days. That will be a good option for this patient.
Yes, sir. One of the doctors had mentioned in the chat box also regarding, I think, thiamine, Dr. Ravindra. So yes, that also plays a major role in managing this patient.
Okay, that's good.
Okay, so if there are no more questions, I think we can close the session for today. Yes, thank you so much, Dr. Divakaran sir, for joining us for this wonderful session on delirium and patiently answering all those questions. Thank you for being with us, and it's over to you, Gayatri.
Thank you very much.
Thank you, Dr. Divakaran sir and Dr. Hashmat ma'am, for the wonderful and interactive session. As always, the session is enriched with much of information. And thank you all guys for the participation. And we are looking forward to see you on the next session. Thank you all.
Bye.